Yeah.
So, good evening, everyone. Yeah, it gives me a lot of great pleasure
Recording
to
in
welcome all of
progress.
you to this track session, which we have with one of our senior experts, Dr. Dayasagar Rao. Dr. Dayasagar Rao is from Hyderabad, and he has done his graduation from Osmania University and subsequently done his FRCS and graduation in UK and Canada. And then he did his DM cardiology in 1975. And for a long time now, he's working as a consultant cardiologist after he retired from professor of cardiology. And he's in practice and he's doing excellent work. We revere him a lot. His talks have been excellent. We have listened to him in different conferences. And he has published a lot of papers in both national and international journals. He's a member of our Cardiology Society and ICC. And today he is going to speak to our postgraduates on constrictive pericarditis, his views of how to approach this and how to differentiate it from the closest confusing diagnosis which come with constriction. So, Dr. Dayasagar Rao, I would request you to start. Yeah.
Good evening to everybody, and I just appreciate my invitation by the CSI Mumbai branch. I'm sharing my knowledge about constrictive pericarditis and its close mimic the restrictive cardiomyopathy. Can we have the next slide? Yep. Why are we worried about this differentiation constrictive? What is common to both of them is both of them present as right heart failure with elevated jugular venous pressure, dependent edema. And if you see by anatomical similarities between the two by way of echocardiography, you will find that atria are dilated, ventricles are normal or even smaller than normal in some patients, and the ventricles are non-hypertrophy. Common to both of them is also most of the patients with restrictive cardiomyopathy, at least in the beginning, will have a normal systolic function, as is the case with constrictive pericarditis. But the diastolic function is abnormal in both constriction as well as restrictive cardiomyopathy. Can I have the next slide? Okay, but then the prognosis between the two is totally different. Constrictive pericarditis, once diagnosed reasonably early, and then has got a very good prognosis, especially when they undergo surgery at the appropriate time and at a reasonably good center in India. Whereas the prognosis of restrictive cardiomyopathy is comparatively very poor, and its management is essentially a drug therapy for heart failure. So this is the major reason why we should separate out constrictive pericarditis, a curable disease, from a controllable disease like restrictive cardiomyopathy. Next slide, please. For us to understand the intricacies of hemodynamic changes in constrictive pericarditis as opposed to restrictive cardiomyopathy, it is important that we understand the anatomy first so that we can appreciate the hemodynamic changes. So basically now, it is important to understand that but for part of the left atrium, right ventricle, and left ventricle are totally intrapericardial, whereas LA is, most of it is extrapericardial. And as a matter of fact, the pulmonary veins are totally extrapericardial but intrathoracic, whereas systemic veins are partly intrathoracic but extrapericardial and partly intrathoracic. So this is the reason why there will be a differential effect upon various structures when the patient inspires or expires. Can I have the next slide, please? So left atrium is not completely intrapericardial. All other chambers are completely intrapericardial. Pulmonary veins are completely intrathoracic. And the systemic veins are partly intrathoracic and partly extrathoracic. Can I have the next slide? Okay, so when a patient or a person inspires, there is an increase in the negative intrathoracic pressure, which is applied to both the lungs and to the heart through the pericardium. Now, if you notice that the pressures and flows, compare it between the right side of the heart and left side of the heart. When you inspire, there's an increase in the flow to the right side of the heart, as right atrium and right ventricle. But mind you, the pressure decreases even though the flow increases. This decrease in the pressure, even though increase in flow, is because of transmission of negative intrathoracic pressure to the right side structures or the right side of the heart, both right atrium as well as left ventricle, or as well as the right ventricle. Now, the same thing, whereas in the left side, there is a decrease in the flow because blood is held back in the lungs. And that is the reason why the pressure also decreases. So, whatever it is during inspiration, there is a decrease in the pressures both on the RV as well as LV. So, in left heart hemodynamics, during inspiration, there's a decrease in the flow and consequently a decrease in the LV stroke volume and a decrease in the systolic blood pressure, usually around 5 to 10 millimeters of mercury. And the pulse pressure, which is a reflection of the stroke volume, also decreases. And because of that, the ventricular ejection time, the QEA2 interval also decreases. And by Doppler criteria, the mitral EV velocity also decreases. And the reverse happens when the patient or the person expires. So this is the basic, normal, fundamental hemodynamics. This is independent of the disease. Can I have the next slide? So what happens in pericardial diseases in general and constrictive pericarditis in particular is there is a dissociation of intrathoracic pressures and intrapericardial pressures. Second, there is exaggeration of the ventricular interaction. This exaggeration of the ventricular interaction is due to fibrotic pericardium, limiting the space available to allow the increased venous return. But important to remember is this fibrous pericardium affects both the right ventricle and the left ventricle to the same extent in most, if not all, the patients. And third important thing to remember is constrictive pericarditis is basically an epicardial pathology involving the pericardium, to some extent epicardium, whereas restrictive cardiomyopathy is basically a subendocardial phenomenon that extends transmurally over a period of time. The importance of that is that subendocardially there is longitudinal fibers. So in restrictive cardiomyopathy, the first abnormality to occur is abnormality in the longitudinal function of the left ventricle. This we can evaluate by tissue Doppler, which we'll come back to that. Whereas in constrictive pericarditis, there is preservation of the subendocardial function, and thus the longitudinal function is preserved. Sometimes it is even exaggerated to compensate for the epicardial abnormality that is present in constrictive pericarditis. Can I have the next slide? So this dissociation of intrathoracic and intracardiac pressures was first demonstrated to be present in constrictive pericarditis using Doppler technique by a lady called Dr. Liv Hartley in a landmark study published in 1989. So this, can I have the next slide? What they did was they did simultaneous right heart, left heart studies along with pulmonary arterial wedge pressure. To your right is the restrictive cardiomyopathy or an what you call as a normal phenomenon, that the pulmonary capillary wedge pressure and the left ventricular diastolic pressure both move in the same direction, meaning that the atrioventricular gradient during diastole continues to be almost the same, both in inspiration as well as expiration. Whereas in constrictive pericarditis, as shown in the right-hand side of the figure, you can see that during inspiration, during the first arrow, black arrow, there is a fall in the left atrial pressure or the pulmonary arterial wedge pressure below the level of the diastolic pressure. So the pressure gradient is reversed to some extent, if not all the time, but at least at the beginning of inspiration. This loss of pressure gradient during inspiration, because of the intrapericardial structure like LV, is not exposed to the negative intrathoracic pressure, whereas pulmonary arterial wedge pressure or the left atrium, which is extrapericardial, is exposed to negative intrathoracic pressure. So there is reversal of the pressure gradient, at least in the early inspiration, continues till the end of inspiration. And only during expiration, there is a positive gradient between the LA as well as LV that allows more filling of the left ventricle during expiration. So this dissociation between intrathoracic pressure and intrapericardial structures like RV and LV forms the basis of abnormalities seen both by echocardiography and also by hemodynamic evaluations. Can I have the next slide? Okay, this is what in a diagrammatic way we have shown that you mark the pressure, intrapericardial pressure remains the same because it is thick and fibrotic. Whereas pulmonary capillary wedge pressure or the left atrial pressure, where the left atrium and pulmonary veins are extrapericardial, they move with changes in the pleural and intrathoracic pressure. So as you notice, during inspiration, there's a fall in the pulmonary capillary wedge pressure. So there is underfilling of the LV and increased venous return to the right side of the heart, not so much from the superior vena cava, but most of the blood comes in constrictive pericarditis from the inferior vena cava. As the diaphragm descends, the intra-abdominal pressure rises. That leads to squeezing of the blood from the abdomen into the thorax. That forms the basis of increased venous return to the right heart in constrictive pericarditis. And this causes shift of the interventricular septum towards the left side. This shift to the left side, coupled with the negative pressure gradient between LA and LV, contributes to underfilling of the left ventricle. And this results a steep fall in the mitral E wave or the flow Doppler across the mitral wall during inspiration. And the reverse happens in expiration. So this respiratory fluctuations and the velocities of flows consequent to changes in the intracavitary pressures as compared to extrapericardial structures like left atrium is responsible for the respiratory variation or the changing velocities of the flow of the blood. Can I have the next slide? Yeah, this is the same thing diagrammatically shown. You can see here simultaneous recording of the Doppler and the pressure waves. And as you see, that whenever the pressure gradient is high, like in the first complex or the second complex, where the E wave is very tall, slowly it decreases because as the pressure gradient decreases. And finally, we reach a stage wherein the E wave is minuscule compared to the E wave at the beginning of the inspiration. So this is the one that is responsible. This exaggeration of the normal variation in the E wave velocity in response to respiration forms the crux of the diagnostic modalities that we use in both by Doppler as well as by hemodynamic data. Can I have the next slide? This is not only happens to the right side, we can evaluate it from the left side using mitral Doppler. We can evaluate the right-sided changes also by interrogating the hepatic veins or sometimes even tricuspid valve flow velocities as well. If you see the tricuspid valve velocities, so the top one is ECG, second one wave is the inspiration and expiration, and the third graph is the mitral valve flow, and the fourth one is the tricuspid valve flow, and the fifth one is the flow in the hepatic veins. Just want you to concentrate on the hepatic veins, because I've already alluded to what happens to the flow velocities across mitral and tricuspid in constriction in both phases of respiration, or inspiration and expiration. Normally, if you see here, the systolic flow velocities in the hepatic veins is much bigger than the diastolic flow velocities. This is normal. And in constriction, this is exaggerated in the sense that systolic flow is much more compared to the diastolic flow. But what is important there here is during expiration, there is so much of difficulty in forward flow that there is reversal of the flow in the hepatic veins during end expiration. This is the crux of the matter in differentiating between normal from abnormal and from constriction versus restriction. These respirophasic changes do not occur with restrictive cardiomyopathy, but these are exaggerated in constrictive pericarditis. So, understanding the pathophysiology and the respiratory influence on the flow dynamics across both mitral valve and tricuspid valve forms the basis of non-invasive diagnosis for constrictive pericarditis. Can I have the next slide? So in restrictive cardiomyopathy, the changes are much less. There's no respiratory variation of the mitral inflow, for that matter, even in tricuspid inflow. Can I have the next slide? But there are some percentage of the patients, even with surgically confirmed cases of constrictive pericarditis, that there is no change with respiration. This is what we call, or Dr. O from Mayo Clinic has published the data, 1997. 12 patients out of 200 with confirmed constriction at surgery, but without any classic findings, that is, without any respiratory changes across mitral and tricuspid valve. The etiology of this non-respirophasic pattern is whether it's a case of mixed restriction and plus constriction, or there is a marked increase in the preload. That means the venous pressure is so high that the respiratory changes cannot be inscribed. So, when you want to separate out these two conditions, you decrease the preload by doing a Valsalva. During the strain phase, you restrict the venous return and thus restrict the flow and thus bring out the respiratory variations. Can I have the next slide? So the same thing in a hemodynamically, which I will come to that later. But suffice it for me to emphasize here, 1989, Dr. Liv Hatley has shown by simultaneous pressure recordings as well as Doppler tracings that both move in a discordant way, by which I mean when you inspire, the right ventricular pressure goes up and the left ventricular pressure comes down. You compare the fourth beat here, during inspiration, the RV pressure goes up and the LV pressure comes down. And the reverse happens during expiration. The LV pressure goes up and the RV pressure goes down. Remember, normal circumstances, it is concordant. It means both fall or both rise. But here in constrictive pericarditis, it is discordant. One ventricular pressure goes up, other ventricular pressure goes down. So this discordant pattern is very classical of constrictive pericarditis. It does not occur in restrictive cardiomyopathy. This forms the hemodynamic basis of diagnosis of constriction. Can I have the next slide? Next slide, please. Okay, the same thing described by the cartoon where, and this is basically because the interventricular septum moves from one side to the other in response to the flows and the pressures. During inspiration, there is a slight rise in diastolic pressures in the right ventricle, slight rise over and above the left ventricle diastolic pressures. And it is this, what you call differential filling of the ventricles in response to respiration, is the hallmark of constrictive pericarditis. Can I have the next slide? The same thing can be demonstrated by M-mode echocardiography. This is a parasternal long axis view wherein M-mode cut is done. You can see the respiratory phase that during the first arrow, upside arrow, you will find that the RVOT is increased in size, and in the expiration, the reverse is happening. RVOT size comes down and the LV cavity size increases. This is a sign of exaggerated ventricular interaction because there's a limited space caused by the thickened and fibrotic pericardium. Can I have the next slide? No, you just go back. Yeah. This is another demonstration of the exaggerated ventricular interaction. This is again the same thing. What is being shown by the M mode here is there is what we call oscillations of the interventricular septum. Remember that soon after the onset of diastole, there is a downward motion.
Hello.
It's
Chandra,
frozen.
hello?
Yeah, everything is frozen.
Huh?
The video is frozen at one place.
Hmm.
I think sir has lost the network.
Umar.
Okay, we'll wait.
Should I call him?
Yeah, I think so, sir.
Yeah, because your network only, I think there's some problem. Yeah. Join, rejoins. Yeah. So he's rejoining. There's some problem with the network, he said.
Right, sir. I think it should be a minute or so.
Yeah. Anyway, let me take this opportunity to welcome our chairpersons and moderators, Dr. Shahrukh Golwala, Dr. Harminder Singh, Dr. Milind Phadke, and Dr. Bharat Dalvi could not make it, so I'll just replace him temporarily. And
A very important topic for all of us. All of us keep seeing patients of constrictive pericarditis.
as he rightly pointed out, one has a very good prognosis if detected properly and early, and one does not have that much. So making a diagnosis of CP is very important. Yes.
Okay.
Have you joined?
Yeah, yeah.
Yeah, good.
Okay, good.
Yeah.
Am I
Let's
audible?
go one slide back.
Yeah, just go one slide backwards, please. Yeah, okay. So this is a sign of a exaggerated ventricular interaction because of limited space consequent to thickened and fibrotic pericardium. Can I have the next slide? Yeah. It's equally important to remember that, as I mentioned earlier, that there is a difference between restrictive cardiomyopathy and constrictive pericarditis in terms of which layer of the myocardium is involved. So in constrictive pericarditis, the longitudinal fibers are preserved because it's basically an epicardial, whereas longitudinal fibers are mostly in the subendocardial region. Whereas in RCM, or restrictive cardiomyopathy, there is a problem with the longitudinal fibers because it is a subendocardial disease, progresses from endocardium to the epicardium. So initially, at least, there is a loss of longitudinal function in patient with restrictive cardiomyopathy. Whereas circumferential function, which is epicardial, is preserved in restrictive cardiomyopathy, whereas it is impaired in constrictive pericarditis. So the torsion, which is combination of circumferential and to some extent longitudinal, is preserved in restrictive cardiomyopathy, but markedly impaired in constrictive pericarditis. Though global ejection fraction is preserved, at least in the beginning in RCM, whereas it is preserved in most of the patients with constrictive pericarditis. So Dr. Narula and Dr. Partho Senugupta presented a data reclassifying heart failure, whether it is predominantly subendocardial or transmural or subepicardial. So if you classify the heart failure in that way, based on the tissue Doppler characteristics, probably you can think of constrictive pericarditis more earlier than what you think of restrictive cardiomyopathy. Can I have the next slide? So the same thing what I said about can be what you call confirmed by doing tissue Doppler imaging. The first graph, the first picture depicting the flow Doppler as well as tissue Doppler, you'll find the E and A, and they will stick to a pattern. E is taller than A. Generally, E by A ratio is more than 2:1, with a decrease in the E wave deceleration time less than 160 milliseconds. It can be as less as 130. It is always less than 160 milliseconds. Whereas in constriction now, you see, there is a very tall E wave. A wave is minuscule, so the ratio is more than 2:1. But compare the E wave of the flow Doppler to the E prime of the tissue Doppler, which is also very much exaggerated. So the general formula what we use for estimation of the LA pressure is flow Doppler E by E prime. Generally, E is larger and E prime is smaller. So you get an equation where the product of that is the LA pressure. But in constrictive pericarditis, both are long. And this is the reason why we say this is what we call annulus paradoxus. Not only that, when you measure the E wave by tissue Doppler in the lateral as well as the medial part of the mitral annulus. Generally, normally, the lateral E wave is much bigger than the medial tissue Doppler E wave. But then in constrictive pericarditis, the medial E prime is much bigger than the lateral E prime, basically because the medial E wave or the medial portion of the mitral annulus is quite free to move in both directions, whereas the lateral one is hindered to some extent by the thickened pericardium. It is this reversal of the thing is what we call annulus inversus. Now compare that with the restrictive cardiomyopathy. Look at the early tissue Doppler wave during diastole, what we call as E prime. E prime is almost always less than 6 centimeters per second velocities. Whereas in constrictive pericarditis, with the preserved longitudinal function, the E prime is by and large more than 10 centimeters per second. So this is the easier way of at least knowing whether it is a restrictive cardiomyopathy or a constrictive pericarditis. Can I have the next slide? So this is what I tell annulus paradoxus, annulus inversus. Paradoxus because usually when the LA pressure is elevated, you expect the tissue Doppler to be smaller and flow Doppler to be larger, and that forms the basis of measuring the LA pressure. But in constriction, even though the LA pressure is elevated, both are tall. In annulus inversus, as I said, normally lateral has got a higher velocity as compared to the medial, but in constriction, it is the other way around. That's why it is called a inversus. Can I have the next slide? Next slide, please. Okay, the same thing about mechanics. I think you can skip that. Can I have the next slide? Yeah. So what is the diagnostic accuracy of various echocardiographic abnormalities? You can also measure pericardial thickness. I'll come to that later. But if you see a 30% inspiratory fall in the mitral E wave is more than 85% sensitive. Specificity is also very high with 90%. So this is one of the important things. In mitral E annulus or tissue Doppler E prime more than 8 centimeters per second really rules out the restrictive cardiomyopathy. And it is more in favor of a constriction. But the mitral annulus less than 6 centimeters, S wave, that is systolic wave more than 6 centimeters per second, that means preserved muscle function, is common in patients with constriction, very rare in patients with restrictive cardiomyopathy. So how do we integrate all the data into one? Can I have the next slide? So this is about the Mayo Clinic criteria of constrictive pericarditis by echocardiography. So what they have shared is there's a ventricular shift with respiration, cyclical shift. During inspiration, moving towards the left side. During expiration, moving to the right side. So this can be demonstrated both by 2D echo and also by the M mode across the RVOT. If that is present, one of the first and most important criteria, the septal shift indicates there is limited space available for the ventricles to fill. So one ventricle has to fill only at the expense of the other. Both cannot fill simultaneously to the same extent. So that formed the first criteria. Then the mitral E prime velocities, more than 10 centimeters per second, and not only annulus paradoxus, but annulus inversus. Both are present. That is the second criteria. The third criteria, what they have used was hepatic venous flow reversal during expiration. And the velocity of the reversal should be at least more than 80% of the forward velocity. If all three criteria are present, it is very highly specific. But sensitivity comes down to 64%. That means only about 60 to 70% of the people will have, patient with constriction will have all the three parameters abnormal. But if all three are abnormal, there's no need to do anything else. You can send the patient straight away for surgical intervention. But by and large, what happens in practice is we have only 2 out of the 3. Ventricular shift during respiration with what you call shifting from right to left or left to right, depending on the phase of respiration. And a medial E prime more than 9 centimeters per second, or hepatic flow reversal during expiration. If 2 out of 3 are present, then the sensitivity is also high, 87%. Specificity is also high, 91%. So you can use depending upon your, skill, depending upon patient to patient. But then you should try to elicit all these 3 signs, echo Doppler signs. So if all 3 are present, then you're very specific. You're lucky in the sense that you caught a patient with all the abnormalities. No need to do anything. But by and large, we have only 2 out of 3. Then your sensitivity, specificity is practically 87 to 90%. Can I have the next slide? Now somebody has got an idea, why are all these hemodynamic diameters, hemodynamic flow abnormalities, the spirophasic thing? Why don't we take just some imaging of the pericardium? If the pericardium is abnormally thickened and calcified, either by chest X-ray, shown in the left half of the picture, or by the CT scan, which shows not only thickening but also calcification. We should sort out the problem. Thickened and calcified pericardium is synonymous with constriction. But then we have a caveat. Can I have the next slide? The same thing can be shown even by the MRI. Can I have the next slide? It has been found that almost about 20% of the patients, can I have the next slide, please? Forward. Next slide, forward. I think this one slide is missing. Okay. In the Mayo Clinic studies, it has been found that 20% of the patients with surgically proven constrictive pericarditis have normal thickness of the pericardium. So the normal thickness of the pericardium does not rule out constriction. So there must be anatomical abnormality, which is pericardium, associated with functional consequences of thickened pericardium. So basically now we can use thickening. Can you go back one slide? Go backwards. One slide. Okay, this is it. So you can also find out thickness of the pericardium both by CT as well as MRI. MRI is preferable. I'll tell you later why. Because if you don't have the facilities for CT or MRI, if you've got a facility for transesophageal echo using 5 to 7.5 megahertz probe, there's a good correlation about the thickness as compared to CT and MRI. The R correlation is almost 0.95. That means if it is thickened by TEG, it will be thickened by CT or even MRI. So where there are no facilities for CT and MRI, you can use a TEG with fairly reliable data. And by TEG, if the pericardium is more than 3 millimeters thick, then this abnormality is 95% sensitive, 86% specific for thickened pericardium. But thickened pericardium is not synonymous with constriction. Just want to emphasize. Basically, in some of the patients who underwent cardiac surgery prior, maybe CABG, maybe wall replacement, it has been found that a fair number of patients who have undergone cardiac surgery without any evidence of constriction by functional evaluation also have thickened pericardium. So thickened pericardium is not synonymous with constriction, and absence of thickening does not rule out constrictive pericarditis. This rule you need to remember during your practice. Can I have the next slide? Okay, next slide. So, are there any biochemical tests or any hematological tests by which we can differentiate restrictive cardiomyopathy from constriction? Yes. Is not in a with heart failure. One of the things you need to remember, probably missing pericarditis, because in constriction the venous pressure is high, not because of increased stretch and diastolic dysfunction of the ventricle, because thickened pericardium restricts the expansion. So the walls on the myocardium is increased in constriction. That's why the BNP levels are not elevated. Can I have the next slide? So basically now echo Doppler, is there a role for invasive hemodynamics in 2025? Answer is yes. What are the conditions? Echo Doppler, there is a
I think we have lost connection again. Rahul, can you sort this out? What is the problem? राहुल क्या हो गया? Okay. पर अभी तो sir is there online.
No, his mic has shown muted. Can somebody call him and tell him, or can you unmute him from the system?
नहीं, somebody will have to.
Can you not
call
do it from your own?
I will call him.
Sir, you are on mute, sir. Dr. Dayasagar Rao, your computer is on mute. We can't hear what you're saying. Ganesh sir, please call him.
Are you able to hear me now?
Yeah, now, yes. But we missed your last 2-3 minutes, sir.
Okay. Basically now, is there a role for invasive hemodynamics in 2025? That is the question. So probably there is still a role for invasive hemodynamics even in 2025, because when the echo Doppler criteria are not fully met, or when the patient has got atrial fibrillation with varying RR interval, and then the interpretation of the respiratory variations becomes very difficult to interpret. Or if the patient has got a complex constriction, meaning patient has got additional myocardial problem, either because of infiltrative diseases or because patient also has a coronary artery disease, or very rarely a poor acoustic window, still we can do it by doing a transesophageal echo. But by and large, in about 80 to 90% of the patients with constrictive pericarditis, we can get the data. In case you are not able to make the diagnosis, then only you resort to invasive hemodynamics. And what do you look for in invasive hemodynamics? The discordant ventricular pressure, which are respirophasic, by which I mean during inspiration, there is a rise in the RV pressure and a fall in the LV pressure. Remember, normally both move in the same direction. During inspiration, the LV pressure falls and RV pressure also falls, even though there is an increase in the venous return. This is normal. But in constriction, it is the other way. So the RV pressure rises and LV pressure falls. And this is reflected clinically also to some extent. That Kussmaul sign, which is an indirect reflection of the right heart hemodynamics, that there is a failure of the pressure to fall or there is a positive increase in the level of the venous column during inspiration. That is abnormal. So that indicates that there is dissociation of intrathoracic pressure from the intrapericardial structures, and also probably to some extent exaggerated ventricular interaction. Can I have the next slide? Next slide, please. I think my slides are gone off.
No, they're there.
No, but I'm not able to see my slides.
We can see it here.
No, but I'm not able to see the slides.
Can you see now?
No?
What can you see, sir?
I see only icons of various people,
Okay.
Amit Mishra.
Sir, you have to go to the
Right.
other page on the left side.
So click on the top left
Top
and
left.
go to switch to speakers view.
No, it is not. Okay.
Sir, when you put your cursor anywhere on the screen, on the top side, you will see one thing where you can see view next to the recording. If you press on that view.
No, this is only recording is their view.
Yeah, next to the recording is view.
No, because
below
it's
recording,
not.
so below recording, there is one switch camera, and below that there is switch to gallery view. Can you see that?
This is gallery view. Is there
Yeah, please
here?
click.
So
please
you
click on
have to
it.
go on to the standard view or onto the speaker.
Just click on
Speaker.
that. Sir. Just click on it.
Speaker view, yeah. Okay.
Yeah.
So this is what it is. Yeah. Can you go back one slide backwards? Yeah, okay. One slide forward now. So the previous classic hemodynamic criteria for CP was equalization of pressures in diastole, meaning that the diastolic pressures in atria and ventricles between the right side and left side or within 5 millimeters of each other. Mind you, it is during diastole. This is basically because the thickened fibrotic pericardium exerts its effect equally both on the right ventricle as well as left ventricle. There is no differential effect. So all of them will act like a single unit, and then the pressures are elevated and they are equal. But then there are a lot of other conditions which also do it. So the sensitivity of that parameter was only 60%, and equally importantly was specificity was only about 38%. Meaning it is of no use in differentiating restrictive cardiomyopathy from constriction based on that. Now, if you take most of the time in patients with constrictive pericarditis, the pulmonary artery systolic pressure does not exceed more than 55 millimeters of mercury. Whereas in restrictive cardiomyopathy, it can go to very high levels. But what we classically has been taught was the so-called square root pattern or the dip and plateau pattern with rapid filling wave of more than 7 millimeters. And equally importantly was the right ventricular end diastolic pressure was on the RV systolic pressure. But each of them had a sensitivity 93, but specificity was very low, indicating that there are other diseases which can cause similar pattern. Then, of course, finally, the lack of respiratory variation in mean right atrial pressure was one of the first signs to be seen. And this is reflected at the bedside as well. Can I have the next slide? I'll show you one after the other. This is the one.
I think he's touching something and his screen goes.
Yeah.
So there?
I think sir is having a network issue, sir. That's it. network gets disconnected, so sir's voice gone.
Sir, use your hotspot.
Yeah. I'm just also using that.
Mhm.
Yeah, okay. So the same thing as I said. Can I have the next slide? Okay, the same thing what I said. You see that initial rapid filling wave, very steep, followed by no filling in the later half of the diastole. So this resembles something like a square root sign in mathematics. So that's why it's called a square root sign. But basically, this sign was, although sensitivity is high, specificity is very poor. That is the reason why it has gone into disrepute. Can I have the next slide? Yeah, this is the one what Dr. Nishimura and his colleagues from Mayo Clinic have produced. Is respirophasic variations in the pressures of the right side as well as left side. The right side is in the orange and left side is in the yellow. You see that during expiration, the LV pressures are high and RV pressures are low. The reverse occurs during inspiration, wherein the LV pressure comes down, RV pressure goes up. This is the so-called discordant movement of the pressures which are dependent upon the respiration or phase of respiration. So in both phases, both in inspiration as well as expiration, there is discordant movement of the pressures. One is going up, other one is coming down compared to the previous cycle. Whereas in the what we call restrictive cardiomyopathy, there is no change between the various phases of respiration. So this is supposed to be very specific and sensitive sign of a constrictive pericarditis. And there was some connection. There was some statement saying that if the patient has the so-called discordant pattern, the surgical results are going to be extremely good. And the specificity was given as 97%. Can I have the next slide? So the same area, one was only pressures, other one was areas, systolic areas between the right and left. It's the same thing. Can I have the next slide? Just like any other, thing in medicine, nothing is 100% correct. This is a case report published in the Journal of Sky, November, December 2022. It's a very interesting case. It's only one case report, but it does bring out a very important point that you can have constriction and yet not have any ventricular pressure discordance. This is a 59-year-old man presented to the hospital with right heart failure. The past history of Hodgkin's disease, for which he was given radiotherapy as well as chemotherapy. Something like 10 years or 15 years later, he presented with severe aortic stenosis. And CT, as a prelude to the TAVR, they did the CT. And suddenly they found there was pericardial calcification and pericardial thickening, apart from classical aortic stenosis, both by physical examination and by echo Doppler estimation. And the TTE, transthoracic echo, revealed no respiratory variation of the flow velocity across the mitral wall, across the tricuspid wall, and no septal bounds. So they thought it was probably only thickened pericardium, but not causing any restriction to the filling. Can I have the next slide? Yeah. You see the middle figure of the CT, wherein you see the inferior portion of the cardiac silhouette, wherein the pericardium is thickened and calcified. The first set of graphs to your on the right side of the picture shows a simultaneous recording of the left ventricular pressures and right ventricular pressures. In a patient with aortic stenosis, you expect the left ventricular pressure to be markedly high. But then there was no respirophasic variations in the peak systolic pressures between the RV and LV. So what they did was initially they did the TAVR, transcatheter replacement, and then they studied the patient after TAVR. About a few months later, the same patient showed what we call phasic variations of the left ventricular pressures and right ventricular pressures, which were discordant, indicating that the patient has a constrictive pericarditis. So now, what is the mechanism by which the constrictive pericarditis was masked was the LV and diastolic pressure was so much elevated that ventricular septum was not moving with respiration because one ventricular pressure was much higher than the other ventricles. This does have a teaching point or a practical point that the entire what you call demonstration of the ventricular discordance is dependent upon the ventricular septal motion in response to respiration. If the ventricular septum does not move for whatever reason, then you will not get ventricular pressure discordance, even though the patient might have a thickened pericardium and constricted pericardium. So a patient with severe aortic stenosis, where the end diastolic pressure was markedly elevated, has to cause a right heart failure. You see the distended jugular in the last figure, topmost figure, before the procedures and after the pericardiectomy. It does show that there is a caveat, that this ventricular pressure discordance has got a caveat in the sense if there is a differential diseases of the ventricle, one ventricle over the other ventricle. For example, here in this patient had what we call a severe left ventricular hypertrophy due to severe aortic stenosis that prevented the ventricular septum moving towards the left ventricle during inspiration. So this lack of movement of the interventricular septum in response to respiration because of severe disease of one ventricle prevented this pressure discordance. And this is what we call masking of the constriction by the differential disease of one ventricle or the other. And I'm sure the same thing can happen if the left ventricular disease is caused by either by coronary artery disease or by valvular heart disease. So this is a caveat we need to keep in mind. Can I have the next slide? So this is a case of a false negative constrictive pericarditis. False negative in the sense the patient had constrictive pericarditis, but the hemodynamic data was against the diagnosis of constrictive pericarditis because there was no discordance of pressures in response to various phases of respiration. So it is possible constrictive pericarditis associated with isolated LV disease, or for that matter, isolated RV disease, can mask the presence of constrictive pericarditis by hemodynamic data. So don't think that hemodynamic data is the ultimate in the diagnosis. Thus, in patients of complex constriction associated with myocardial disease, missing the disease is still a possibility by hemodynamic data. So the importance of pericardial thickness by multimodality imaging should caution us that we may be missing and we need to really look at the other parameters before you say that there is no constriction in this patient. Can I have the last slide? So how do we go about finally clinical examination? Clinical features which are suggestive of diagnosis. What is the purpose of clinical examination is to evaluate the pretest probability of a disease. So what is common to both is right heart failure, JVP elevated, ascites precox, that is ascites preceding dependent edema, is one of the features of constriction as compared to restrictive cardiomyopathy. So that probably should alert you. Mind you, most of the patients with constrictive pericarditis are ambulant. They come walking into your consulting room as opposed to restrictive cardiomyopathy, they come on a wheelchair. But this is basically because in constrictive pericarditis, their cardiac output is reasonably well maintained as compared to restrictive cardiomyopathy. Kussmaul sign is present in both diseases. But then dissociation of intrathoracic and intrapericardial pressures by way of venous pressures and response to respiration in the present era where clinical examination has gone to the backseat is difficult to expect from the residents and from the consultants. Finally, an interesting clinical finding. Is there any physical sign of exaggerated ventricular interaction? The answer is yes. This sign was described almost in late 70s and early 80s. Normally, when you hear the splitting of the second heart sound, with the onset of inspiration, it takes 3 cycles before you hear the separation of A2 and P2, by which we mean onset of inspiration does not cause splitting, but it cycles after to the other side. Remember, splitting of the second heart sound is partly due to, or 70% is due to prolongation of the RV ejection time, secondary to increased blood, and partly Am I audible?
Yes.
Okay, so exaggerated ventricular contraction can be picked up by physical examination or suspected in the biclinical examination, wherein you hear the split immediately after the onset of inspiration, as compared to the usual ones where it takes 3 to 4 cycles after the onset of the inspiration. This sign is very subtle. It takes some time and what do you call concentration to appreciate this physical sign of immediate occurrence of splitting of the second heart sound with the onset of inspiration. The subtle sign, but probably it has not been tested to see what is the sensitivity and specificity. But this is a sign that can be remembered. Can I have the last slide? So this is a summary of the clinical approach, wherein we need to integrate the clinical features with the laboratory data, including ECG and chest X-ray. And then, of course, advanced cardiac imaging using echocardiography and cardiac MRI and cardiac CT. And in 1/3 and in very rare patients where it is difficult or conflicting data are there, you may have to resort invasive hemodynamics, only to realize invasive hemodynamics also has got a pitfall in the evaluation. Thank you, ladies and gentlemen, for your attention. I'll take on any questions if you have any. Thank you, Dr. Kane, and all the colleagues of CSI Mumbai.
Hi. I hand it over to our chairpersons, Dr. Shahrukh Golwala sir, Harminder Singh sir. Please.
This is Shahrukh Golwala. I hope you can hear me.
Yeah, sure. Yeah. I can hear
Yeah,
you.
sorry, I'm not visible. There's some camera issues here. Excellent presentation. I learned a lot, just revised a lot from what we already know. I was just curious, when they say the septal bounce is to be looked for, is it easily seen on even a good echo window? Because this is something which is mentioned, but I don't know if we really come across it very easily.
No. septal bouncing is a very frequent sign, and actually you need to really look at four-chamber view or a parasternal long axis view. You can see the what we call septal bouncing. It's something like a tennis ball bouncing more than once. It's just a quick forward, anterior and posterior movements.
Saruk, I think it is like LBBB pattern, In LBBB, you get septal. That's one of the differential of that septal bounce.
Yeah. Okay.
Yeah.
Thank you.
Can I ask one question, sir? Can I ask one question?
Yeah,
Sure.
please.
Sir, one condition which can cause both restriction as well as constriction is post radiotherapy heart disease.
Yeah.
So in one of the cases, there was a very difficult thing to decide whether the patient has both or it has either of the disease. So please give us some pearls where we can differentiate a mixed kind of disease, sir.
Mixed kind of disease is difficult in the best of the centers in the world, but then you can separate out the pericardium from the myocardium using tissue Doppler is one of the things. Evaluating the what we call the endocardial function versus the epicardial function and pericardial function. For example, in one of the cases, even in the last case where they had a combination of left ventricular hypertrophy and disease, patient it was difficult to diagnose because none of the data were there either by echocardiogram or even by invasive hemodynamics. The only suspicion was that the pericardium was markedly thickened and calcified. So after correction of the primary disease, they will be able to find out. But there are some cases wherein, if you are in doubt, probably as the old textbooks used to say, that you may have to do a thoracotomy. That is the last resort. But it is important to realize that pericardectomy is one of the high-risk surgeries. The mortality is something like not less than 10%, even the best of the centers in the world. If you compare that with 1% mortality with CABG, people will be think twice before you subject this patient for surgery. Coming back to your question, how to separate out pericardial disease from myocardium, a mixed disease? Answer is it is very difficult. You can attempt to do it both by tissue Doppler and flow Doppler.
So in the case which I am referring now, so we did MRI. That showed thickened pericardium as well as there was, late gadolinium enhancement, subendocardial and mid myocardial kind of this thing. So we were still very, very confused whether to send the patient for surgery. Surgeons practically refused to take up the case.
Even with isolated constrictive pericarditis, the mortality is high. Imagine a patient having constriction
and restriction.
Can I ask one question to Dayasagar sir? Vaibhav here. Can I ask one question, sir?
Sure.
Go ahead.
Sure.
Sir, in one of your slides, you mentioned about measuring the pericardial thickness on transesophageal echo.
Yeah.
How frequently have you done it, and I mean, how sensitive it is?
This is a study that has been done systematically by Dr. Oza from Mayo Clinic Group. Personally, nowadays, nobody ventures to do that. As I said in my talk, this is only for those areas where CT and MRI are not available or accessible or affordable. That becomes the issue. Then you can use it. I'm not suggesting for 1 minute that TEE is the gold standard for measurement of thickness.
Sir, can I ask a question?
Yeah, go ahead.
Yes, sir. Actually, we have a lot of PG students attending, and for their sake, I will first ask a clinical question in 2 parts. So students are a little confused and a little, in the dark about the JVP findings in constriction and restriction. So can you give them a short kind of overview, sir?
So basically, am I audible?
Yes, sir.
Okay. Basically, when we are describing the jugular venous column, I keep telling my students that you have to describe the pressure is normal or abnormal first. So the first is in both the patients, the jugular venous pressure is elevated. Then second thing is that what happens to the venous pressure when the patient inspires normally, not exaggerated inspiration, but normally. Normally it should fall because the negative intrathoracic pressure decreases the RA pressure, so the column will fall. But failure of the venous pressure to fall is the first sign that probably you're dealing some kind of a restrictive heart disease or a constrictive pericarditis. It does not differentiate it. In one of the states been shown that Kussmaul sign is positive only in 50% of the patients in constrictivitis. In a textbook written by they said in their hemodynamic study they have never found a rise in venous pressure. But take Kussmaul sign as a failure pressure to fall, probably you can find it in about 15% of the patients. So does it differentiate between constriction and restriction? The answer is no. It only tells you that this patient is right heart failure, and when you do an echo, the echocardiographer gives a
No, we have lost your voice, sir.
What happened? Okay.
No, we have lost his voice again.
Yeah, I think we can conclude now. Is that okay? Or we wait?
No, I was just wondering whether there were any audience questions, but so far it doesn't look like.
Doesn't look like, yeah. Dheeraj, are there any chat questions? No, I think. So, Bhavesh?
No, thank you.
Yeah.
Yes.
I think it has been a wonderful, educative talk from legendary Dr. Dayasagar Rao. I will ask our colleague Dheeraj to give a vote of thanks because he has done a lot of hard work for this. Dheeraj, please.
Thank you, Bhavesh sir. At the onset, I would like to express my profound gratitude to Dr. V. Dayasagar Rao sir for having deconstructed the clinico-pathological and hemodynamic characteristics of constrictive pericarditis and restrictive cardiomyopathy, a very difficult topic to teach students indeed. And of course, I would like to thank Dr. Milind Phadke sir, the president-elect, Dr. G.R. Kane sir, the president, and all the active members of the executive committee who have worked tirelessly to bring this program to fruition. And I hope the students will also be providing the YouTube link in a couple of weeks so that the students can make notes and revise the concepts that were highlighted in the program today. And let's hope we hope and pray that we are going to meet again about in the next month with another interesting topic. That's all.
So, Milind, any other? Yeah, so, yeah.
No,
So,
I
thank
think
you,
we
sir,
just.
Dr. Dayasagar Rao. It was... Huh? Pardon?
No, I was just completing what Dheeraj said. We will have a meeting next month, which we will shortly announce, online meeting. And I just was going to request you to conclude last remarks.
Okay, yeah. So, Dr. Dayasagar Rao, we have this PG track every alternate month nowadays. So, we are going to continue that and send you the invite for participating in it. And so we are doing PG track, we are doing regular meetings as well as Zoom meetings for interesting topics. So the next topic that we have selected is amyloidosis. We are going to have that on 19th of December. So I'm looking forward to everybody participating, and because these are some of the things which we always find it difficult. So thanks everybody, and let's meet soon. Thank you. Thank you so much.
Thank you. Keep up the good work, Dr. Kane and others.
Thank you. Thank you.
Thank you.
Yeah. Bye. Bye. Bye, sir.
Bye.
Bye.